Hello and happy Teach Me Tuesday. Welcome to our new background. Today we had another snow day, no school day here in the Midwest. So my children destroyed the room I usually record these in. So today we're coming from just a slightly different location in my house. But today we're going to talk about two of the most common abdominal wall defects, gastroschisis and omphalocele. So, if we are talking about these abdominal wall defects, we need to really think about what am I seeing and how is it covered? Because when you go and you see an omphalocele or a gastroschisis delivery, or you know you're going to admit one of them, you know primarily you're going to be seeing something outside the body in a place it shouldn't be. But if it's covered in a membrane, if it's right next to the umbilical cord, then those are the questions you're going to ask yourself to really dig into what is this and what am I seeing. So also they can see that on prenatal ultrasound, kind of what's going on, where it's at, and the differences between those. So let's talk about omphalocele, which by the way is a great word. We can put it up there with hyperbilirubinemia. We all know I love that word. Medulla oblongata, another great word. Omphalocele, and can you go wrong here? So an omphalocele is a condition where the abdominal organs, such as the liver, the intestines, maybe other organs, are protruding through the abdominal wall and are covered by a membrane. I have seen many omphalocele in my career. However, in the last few years, I have seen some giant omphalocele, which I had never seen before. And they are so big. It's like a cone almost on the outside of the baby. They're still covered by this sac or membrane. They're usually beside the umbilical cord, so has a covering next to the umbilical cord, and is often associated with other chromosomal anomalies. Those three questions bring you to omphalocele. But these, omphalocele can often be there and be really big. And if the liver is involved, you can imagine what it's like to have to get all of that back inside the baby, which is part of what we do in the NICU as part of our ongoing care. So the treatment options for babies with an omphalocele, seen again here, there's the covering next to the umbilical cord. The surgery is often performed in stages, and that goal is to gradually return the abdominal organs back into the cavity. You can use a silo closure. We call them silos. This bag may need to go over the organs. This is often wound care, right? It's this very exposed part of the baby that really is subject to infection, temperature instability, breakdown in kind of the skin, and also this can be closed with a primary closure. So for some of our smaller omphalocele, it could just be this quick single procedure that the baby has and it goes back in. But often we are doing this stage surgical repair where some of it's going in and we're kind of allowing the abdominal wall and the muscles to grow to make room for more organs as they come in. So those are those key points of kind of what do we have to do with all this that's on the outside to get it back on the inside. And that is very slow and methodical in the staging. And babies are going to go home with some of this still on the outside if they have a giant omphalocele. This might not be fully closed before the baby goes home, which is something else I didn't always think about. I'll tell you more about that here when we go on. So let's talk about a gastroschisis. So a gastroschisis is a congenital anomaly where the abdominal wall doesn't form properly, and so the intestines are protruding out. They are not covered in a sac. There's no protected membranes. They're exposed to the amniotic fluid in utero, and then the temperature changes as the baby comes out, and it's typically to the right of the umbilical cord, so further away. And it's not usually associated with any other anomalies. So omphalocele has a protective membrane right by the umbilical cord associated with other anomalies. Gastroschisis, no covering to the right of the umbilical cord and not associated with other anomalies. Those are kind of those categories that you can put them into. So when we talk about the gastroschisis, this is a surgical repair. It usually involves the exposed intestine back in, so we can go in and we have babies that are admitted, go to the OR the same day, and are treated. It's back in, we kind of do the rest, getting them off the ventilator, getting them onto full feeds, etc., making sure everything works, that they're digesting and pooping and all of that. Or we might, again, do that silo bag closure. So this might be the time where we put it in a bag to protect it, and it's kind of compressing over time. It's like this little cinching, or I think of it like an icing bag. When you're trying to get the icing down to the bottom, it's kind of the same idea. We're slowly moving it down, and they're return to the abdominal cavity. So what's great about my career as a NICU nurse is that I have worked in a variety of different hospitals, but kind of the two main ones I've worked in, one was not a surgical hospital and one is. So where I worked previously, we did not do any of these abdominal wall defect surgeries, but the babies would be born there and we would stabilize and ship them. And I somehow got into this pattern where I was like getting gastroschisis all the time. And, somebody is sterile, we're getting the baby into a bowel bag, preparing them for transport. This was like my jam. For some reason, me and the gastroschisis were happening all the time. So really, one of the things you're also looking for at birth is making sure that it's pink and intact, that nothing happened to it on the way out, that it's well perfused. So that's all part of the admit nurse's job, together with the healthcare team, to make sure that everything looks great. The baby, like I said, where I work now, we're surgical abdominal, wall cavity. We do surgeries for abdominal wall defects. There it is. And in addition to many other things. But sometimes with these known deliveries, the surgeon comes, they see the baby, and they're like, okay, let's take him to the OR now. And they're in the OR within a few hours of birth. So then they just kind of get it back in there, depending on how much was out, what it looked like, what the growth of the baby was like. And then I've seen the silo with kind of that stage closure and then a surgical closure at the end. Again, I'm kind of allowing that abdominal wall to grow and change with the baby. So two kind of different treatment options for them. With the omphalocele, you really are more seeing a gradual return to the baby over time, less of that same day surgery kind of going in and getting it back in. So our nursing interventions, we are going to have pre and post-op care. So with our pre-op care, making sure we have our access ready to go, emergency medications, etc. But post-op, we really are looking at the surgical site and assessing for signs of infection. With the omphalocele, if the baby doesn't have surgery right away, this is going to be part of your wound care as well. With the gastroschisis, if it's an immediate return and the baby has surgery right away, these are things you're going to be assessing like a newborn skin assessment with this postoperative care kind of right away. We are also going to provide nutritional support so that we can get the baby growing. Especially if we have an omphalocele, we're going to need really good nutrition and hydration because so much is still exposed during this time. So wound care, that's going to apply to your babies with the staged closure, with the silo, or with this omphalocele that might have to have a protective membrane on it. This is something that we are going to be teaching parents as well. That's going to be a big part of your discharge teaching. Respiratory care, especially as the baby's growing and then and parts of the intestines are going back in, it can compromise the lung expansion. So just helping the baby with their respiratory support. But one thing that I think is so important for us to remember is thermoregulation and temperature control for both during the delivery and immediately following. If you think of those babies with a gastroschisis, with those exposed abdominal contents, right? They have no protective covering there. We might need to keep them warm, but also a radiant warmer can in fact dry some of that area out. So do we need to put warmers underneath them? What is this temperature regulation going to look like? Making sure they have a hat on, ensuring the baby's appropriately covered and swaddled as needed as they're closing in. The defect. Is the radiant warmer good for them? Of course, right? The radiant warmer is going to help keep them warm, but it's important to just remember what is exposed and keeping it well moisturized. That's going to be really true for your omphalocele as well. These babies are going to go home. They're often going to go home with this still out and exposed. So they're going to need temperature control of what kind of clothes can we get on them, what does their swaddling look like, what does their safe sleep look like, so that they can effectively discharge from the NICU. Our long-term outcomes are actually pretty good. The biggest issue, and I have seen this myself in my career here at my current job, is for the giant omphalocele. First of all, it can take a long time for it to be ready to go back in as the abdominal wall is stretching. So it can rupture on delivery. It can rupture in their time afterwards in the NICU. And then as it's going in, they also are at risk for abdominal compartmental syndrome. We actually had that with a post-op baby. So she came back in after about 11 months for her closure and had some complications from that. Just because you're returning all these contents back into the stomach and into the abdominal cavity at a period of time. Though that's also going to impact their respiratory system. So there's more long-term problems there. Gastroschisis, these babies, can have atresias from this time spent where there's entanglement or outside of the baby's body. So they can have bowel damage and strictures. But overall, these babies do actually pretty well. Some things that they just might have to deal with as they get older as far as the atresia or the strictures go. So parent education, a few things I didn't ever think about in my previous job because we stabilized and shipped them. Our goal was for them to be in the ambulance 1 hour post-birth. Did it happen every time? No. No unit is perfect. I like to remind people of that. But we really have to have extra attention to wound care, positioning, making sure that the baby can safely move their body and still be getting developmental positioning. They're not going to be able to lay on their stomach. So what is their head shape looking like? Are they getting time off the back of their head? I've recently been learning a lot about car seat safety and omphalocele. So there are special car seats for these babies. They are extremely expensive. We're talking thousands of dollars. So how can we best support parents in getting their baby home safely? Would that need to be something like a car bed? What would we need to do? Do we need to get them connected with a foundation or donation so that they can get their baby home safely? But also they need to learn wound care, right? There's going to be skin care and wound care if the baby is going home with a still exposed omphalocele. And for those babies that did have a gastroschisis, is just watching their stool, watching their output, making sure that their stomach remains soft and non-tender. All these are going to be really important for us to do as part of our parent education. So when we're talking about these things, we are asking ourselves, is there a membrane? Where's the defect located? And are there any other findings or other anomalies present? That's going to help us really understand kind of what we need to do next, what we need to have prepared, what positioning is going to look like. Do we need to intubate right away? Is the baby going to need surgery right away? And then going through the surgery or staying in the unit, we will support them through respiratory support, nutrition support, feeding, wound care of the closure after a gastroschisis, just making sure that the wound and our closure is going okay there. Our discharge teaching, what does positioning look like? What does stool output look like? How can we make sure that the parents are doing the dressing changes? Are they there for the daily or every other day dressing change that their baby may need? Are they the ones carrying out that dressing change so that they can effectively do that at home? And if we can do all of those things, we'll be able to provide safe and quality care for all of these babies. Thank you for joining me today. We have a special thing this month, and that is that we have a 5th Tuesday in January. So I will see you next week for our last January special teaching, Teach Me Tuesday. And then when we move into February, as you can imagine, there's probably a theme. So something exciting coming forward in February. But have a great day, and I will talk to you next week.